So one of the things we're really interested in doing is measuring change in our patients in a way that's quick and efficient. So when we select an outcome measure, we really want to know the data, the criteria that we can use to establish an actual change in our patients. So we're going to compare the MCD and MCID and then go through how reliability and validity help us select an outcome measure. So first, let's define things. So minimal detectable change is really about the smallest change that statistically we can rely on given just errors in applying the measurement. So this is just about the minimal change that's above error. But when we move toward minimal clinically important difference, or the MCID, here the definition changes and it's more about the meaningfulness of the change that we're measuring. The smallest differences in the score in the domain of interest which patients perceive as beneficial and which would mandate, in the absence of troublesome side effects and excessive cost, a change in the patient's management. So we can see here is there's two key elements of this definition, which is that there's a minimal amount of change reported by the patient, and that change is important to the patient or to the management of that patient. So the key points is that MDC is about error, and MCID is about meaningful change based on patient perceptions or something relevant to management. This means that patients may experience real change as a result of your intervention. However, they may not think of themselves as better until they exceed a certain threshold. And this is the basic concept that MCID is trying to capture. So to kind of get an idea of how this works, let's go over how a study would actually be set up. In order to determine an MCID, what we would need is the scores on the measurement we're interested in, and then we'd also need something about patient perceptions of how they value the change they're experiencing. So one way we would do that is to anchor our estimate of the patient's perception with a Likert scale. And so what we might do is, after some interval of care, ask them to rank themselves according to this simple questionnaire where they rank themselves as totally recovered, moderately better, mildly better, same or worse, and then compare that to the scale scores that we're interested in evaluating. So this is a good example. So here we've collected data over an interval of 2 months or plus or minus a couple weeks, and we have initial scores on something called the MCD, which is a shoulder evaluation for rotator cuff problems and impingement problems with the shoulder. And all of these patients have different shoulder problems. And we've measured an initial score and an 8 to 12 week follow-up score. Now, at the second visit, we also gave them the perceived improvement scale, and we can see down here on the x-axis is they've been ranked as totally recovered, and the patient ranked themselves moderately better, mildly better, the same or worse. And then we can look here on the y-axis and see how those categories rank on different scores. We can see essentially all of these people to the left of the dotted line we would consider, okay, somewhat improved, and hopefully the treatments we gave them helped that along. And then the patients to the right of the dotted line either the same or worse, so they really didn't respond to treatment. Now, what we could do is say, what's the minimum change on the scale to capture all these individuals to the left and that felt like they were at least mildly better? So we could kind of move up here and say, okay, if we wanted to capture the whisker box there, all those people, that if we drew the line essentially somewhere in here around 10 points, it would capture most of the people that had experienced at least a minimal improvement. It would overrank a few people here as misclassify them as improved, because everybody above 10 points we'd say is improved. But it would correctly classify all these people down here as not improved. And so here's our errors. Our error groups are here and here. And so you could see that we have basically the same kind of contingency table situation we had when we did diagnosis, or we're using sensitivity and specificity from before, where there's all your true positives, here's all your true negatives, here's your false negatives, and here's your false positives. And so we can essentially use the same strategies we did for for diagnosis. Or we can use an ROC curve and then apply sensitivity and specificity to the data, and then determine what the optimum cutoff would be to minimize the number of false negatives and false positives, people who hadn't actually improved, that we say are, and people who didn't get worse and actually did, right? So we're misclassifying people. And so essentially what this does is gives us an estimate of what the best MCID to use for that particular questionnaire would be. So that's a good example of how an MCID would be determined using the anchor method. And here's some of the issues that, if you reflect for a minute about that approach, we tend to think that there's one MCID per instrument. But essentially, different disease populations may respond differently over the kind of intervals that we measure them or that we see them. And so smaller amounts of change may be more important or relevant to some people than others. And if people are more severe, a smaller amount of change may also be important to them. So there's different issues with determining one MCID for an instrument. The last thing is that there's different ways of calculating an MCID. The anchor method, though, is the preferred way. But in terms of clinical application, even though there's some ambiguity in terms of an exact MCID value, having an estimate of an MCID is clinically useful to us, because otherwise we have kind of no marker of what might be an important difference for a patient. And so it's much better than the alternative of not using one at all. So now let's look at how MCIDs and MCDs and reliability statistics and construct validity, that includes convergence and divergence, is used to choose one scale over another. So this is a systematic review that was published in 2009 on different shoulder tests. You can see here there's the DASH, SPADI, ESSIS, and the SST. These are all different shoulder tests that have been proposed and have published data on them. And so what this article is intending to do is compare all of these variables between the different shoulder tests in an effort to demonstrate which ones have good reliability and validity and could be useful clinically. So let's look at some of the items they're identifying. So floor and ceiling effects, responsiveness, which the only variable of these that we've covered is the MCID, test-retest reliability, which includes ICC, standard error of the measurement, the MDC, and then ideas related to validity, construct, content, and then we didn't cover factorial or internal consistency. But many of these we've covered and you can use to select the questionnaire. So in the results, they tallied all the articles that have been done on the different studies, and we can see them here. The American Surgeons Elbow Shoulder Scale, the DASH, the SPADI, and the SST. So then we have different disease groups that these things have been evaluated for. So 16 of the articles, or I guess one of these are rotator cuff tendonitis issues, and they looked at the time to complete the test. So these are kind of practical considerations. So for all of these scales, we can see that in essence, the time to complete in minutes is pretty low, somewhere between under 5 minutes for all of them, irrespective of the disorder. And then if we look at something called known group validity, where we're taking people that we know that they have a problem and comparing the two scales to see if it detects it. And these are, in this for the DASH, they looked at people with known levels of range of motion impairment versus those that didn't have it, and it was significant. And the same for this simple shoulder test, and people who were on workman's comp status and were not, and that was also significant. So those two scales were valid for those known groups. And then in terms of reliability, this is our consistency measure. We see ICC, SCM, and MDC values here, and then the different disease populations. So for shoulder arthroplasty, shoulder disorders in general, pre-surgical and non-surgical, or post-surgical, non-surgical shoulder pain dysfunction, and then tendinopathy impingement problems. They've said they've been categorized. We can see that the ICC values are what's given here for most of them. And in terms of the ICCs, we generally said in the range of 0.9 is excellent. And so all of these scales have some readings of excellent with some groups, and then some are a little less good, but still 0.8 is still very good. And then for one of the studies, we get a minimal detectable change from the DASH and the SPADI. And we note that the detectable change for the DASH is better, so just based on this, we might choose the DASH as a test for measuring change. And then we have another measure here where the DASH again beats the SPADI. Now this is a more construct validity scale because they're about known groups. And so here we can look at the different known groups and ask the question, well, is that each scale valid for the different comparisons they've made? And we'll just focus on the DASH for a minute. So it was able to detect differences in people who are currently working and not working. And we can see the range of values. So the people who are not working had scores that were much higher, almost twice as high as those currently working. And so where low is better on the DASH, a low score. And then we had people who were able to do what they wanted to do, had much lower score than people that weren't able. And so we can see is that as we go down and look at the different comparisons, that in general the DASH picked up important differences between the two groups. And so when you look at that, it seems like, okay, for this kind of known group comparison, it seems to be sensitive. And so we could also look at reliability, and responsiveness to change, and that's what's listed out here for all the different scales. And first we note the range of ICC values for each one of the scores and the number of studies supporting it. And we can see that in terms of the different scales, the SS has 5 studies, the DASH is 15, the SPADI 6, and the SST 2. So the most popular scale to study by far is the DASH, which is supported by much greater numbers of studies. But the average ICC for each one is really quite high, and they're all really in the acceptable range, which is near or above 0.9. And then if we look here, we can see that now let's look at the actual scores that we would have to use to detect change. And this is at the less conservative standard error of the measurement level. And we'll just go to the averages here across the different studies, even though for the ASCS it's just one. But if we look, we can see that the ASCS is 6.7 points, the DASH is 4.5, the SPADI 6.8. And so if you just looked at those, the choice would be the DASH. It has the smallest increment of change for us to detect something important. And then the MDC, which is more conservative, and there's 2 values of it. There's a 90%, which is a little less conservative, and a 95%, which is even more. And we can see the different values for that here. And now if we look here, we have 3 of these studies for the DASH, 1 for the MDC, and 1 for the SPADI. But in essence, the DASH and the SCS is about the same, but the ASCS is the lowest. So on this particular item, we would go with the ASCS. And then if we make it more conservative, what's happened is the DASH stays about the same. So about a 10-point change for an MDC, and then for an SCM, which is more liberal, it's 4.5, would be necessary for a real change to have occurred. Now, the final thing that's on this particular chart for comparison is the MCID. And again, we have the range of scores here and then the average, but essentially most of these were not averaged. So if we look across that, they're all kind of even. So both the SCS, DASH, and SPADI, with really the ASCS having the lowest MCID. And so So what we can conclude from this is basically all three tests have adequate measurement properties to be used for the data collection. With the SST really needs more development. There's clearly a lot of information we don't know about how to interpret that test. So a better choice would be the ASCS, the DASH, or the SPADI. And essentially, it'd be up to you in terms of your clinical preference, in terms of the content, your clinical setting, things like that. And so the winner really is these top three tests that we kind of know their qualities, can determine some estimate of a minimal change, and also have an idea of what the MCID is. And what's interesting, I think, and a lot of the students will say this, is that it's surprising sometimes when we think about the minimal detectable change, and in essence, what's happening is it's matching up with the MCID at some level. Sometimes even, I think in one example here, if we go back, the MCID is actually lower than the MDC, which is estimated from a different study. And so what I think that reflects is just how the estimates of MCID are evolving, how the different techniques that are being used to define it are being utilized, and that the different factors like population and severity influence the MCID. But without it, we really are at a loss of how to document a clinically significant change in the scale when we're treating patients and looking at randomized controlled trials. Thank you.